Assessment of musculoskeletal function in skin. This program is offered by the Beacon Institute. Funding for this program was provided by the Office of Healthcare Quality under a grant titled Improving Nursing Staff Knowledge and Skills to Identify Changes in Resident Status. This program should enable you to identify the age-related changes to the musculoskeletal and integumentary systems, identify disorders of the musculoskeletal and integumentary systems commonly seen in the long-term care setting, describe the basic assessment process of musculoskeletal and integumentary systems, and incorporate assessment information into nursing diagnoses and care planning. A variety of changes occur to the musculoskeletal system with age. Bone density starts to diminish after age 30, and there's a loss of calcium and other minerals. This especially accelerates in women after menopause. The risk of fracture increases. Cartilage inside the joints thin and the components become altered. Fluid is lost and joints become less resilient. Connective tissue and ligaments and tendons become more rigid and brittle. Joints become stiffer, reducing the range of motion. Reduction of muscle mass and strength occurs, and changes in muscle fibers cause muscles to contract more slowly. There's increased stress on certain joints, which may cause damage. An estimated 2-inch loss of height occurs by age 70. Exercise can help to counterbalance these changes. Certain conditions become common in late life. Arthritis refers to joint pain and stiffness. There are several different kinds of arthritis. Osteoarthritis is a degenerative form due to wearing away of cartilage and resulting bone against bone action. Pain, swelling, and stiffness result. Rheumatoid arthritis occurs when the immune system goes haywire and attacks joints and possibly other organs. It causes joint erosion and can lead to permanent joint damage. It brings more deformity and disabling than osteoarthritis. Osteoporosis refers to weakened, brittle bones due to hormonal loss or deficiency of calcium or vitamin D. Osteomyelitis is an inflammation of the bone due to infection. Generally, it occurs in the legs, arms, or spine. Infection can enter from the bloodstream or an open fracture or surgery. Most of the time, it's caused by Staph aureus. Compression fractures, usually of the spine, can occur, often because of osteoporosis. The vertebrae start to crumble. Contractures are a permanent shortening and hardening of muscles, tendons, or other tissues, leading to deformity and rigidity of joints. As you recall, federal regulations require that we provide care and services to residents to help them attain and maintain their optimal level of function, and this involves musculoskeletal function. Strength, flexibility, and balance are crucial elements to the maintenance of ADL performance, so these things are important to evaluate in the nursing assessment. As per usual, the assessment starts with careful observation and inspection. Physical abnormalities will impact how well a person can perform movements required for the activities of daily living. When observing, note how the resident is able to change positions, his balance, and his coordination. Note if assisted devices are necessary. Note abnormalities of gait. Ataxic gait is unsteady. The feet are raised high and drop flat on the floor. With hemiplegic gait, one foot is dragged with leg circumducted. The arm on the same side is flexed and held close to the body. Parkinsonian gait is characterized by shuffling steps that pick up speed, a forward-leaning posture, and no arm swing. If the resident uses a wheelchair, note how well the resident is able to propel and position himself. Ask about any changes in the ability to move. Have the resident perform active and passive range of motion exercises and note any limitations. Have the resident grab and squeeze both of your hands. Note strength or weakness and differences between the hands. To assess motor function, have the resident assume an upright position. Ask him or her to close the eyes and hold their arms out straight, perpendicular to the body, for approximately 20 seconds. Note weakness and the inability to maintain the position, which could be associated with hemiparesis. Assess the arms and shoulders by asking the resident to hold the arms straight and resist your efforts to push them down. Ask the resident to raise the arms over the head with palms forward and hold that position for approximately 20 seconds. Weakness or swaying of the arms could be associated with hemiparesis or shoulder girdle disease. Test hip abduction by having the resident lie in bed. Place your hands against the outer sides of the knees and ask the resident to spread his or her legs and push them against your hand. Test hip adduction by placing your hands between the resident's knees and asking the resident to move the legs together. Test hip flexion by placing your hand on the resident's thigh and asking the resident to flex the hips, raising the leg against your hand's resistance. Be sure to test both legs. Weakness could be associated with neuropathies or muscle disease. Assessing motor function includes testing plantar flexion. Place your hand on the undersurface of the resident's foot and ask the resident to push down. Test dorsiflexion at the ankle by placing your hand in front of the foot and asking the resident to pull the toes up against your hand. Weakness could be associated with neuropathies or muscle disease. The cerebellum is responsible for smooth, coordinated, voluntary muscle movement. It affects posture, balance, coordination, as well as speech formation. Test hand coordination by asking the resident to rapidly tap his hand on the leg, turning the hand over from the palm and to the outer surface approximately 6 times. Ask the resident to touch his or her thumb against each finger on the same hand. The inability to perform these tasks could be associated with cerebellar disease. Some nurses state they don't understand the MDS or its coding. This slide provides a summary of MDS coding for ADLs. Note that with the exception of 8, the higher the number, the more help the person needs with that activity, which means if the codes change from a lower to a higher number, that resident is showing a decline. That decline should be reported to the physician as well as to the rehab services. The reason for that decline should be assessed and addressed promptly in an effort to return the resident to his or her baseline. The care plan needs to be updated with new measures that reflect what you're doing about it. Your notes must address your efforts and results so that if new measures are not successful, you'll have the necessary documentation to prove the decline was clinically unavoidable. Some potential nursing diagnoses associated with mobility and pain are shown here. Sample approaches to addressing the problems are shown on this slide. When it comes to maintaining physical function, occupational therapy and physical therapy should be your close allies. Communicate with one another to assure proper assessment and follow through with care. In your care plan, specify specific types of support needed. Avoid general comments. Now let's turn to assessment of the skin. The skin undergoes many changes with age. There's a thinning of the layers of the skin, the dermis and epidermis particularly. Some of the fat layer is lost. Diminished essential oils cause the skin to be more dry, less elastic, and form wrinkles. Sensations diminish due to decreased nerve endings. Sweat glands, blood vessels are decreased, and there's decreased response to heat exposure. Melanocytes are reduced, and there's less protection against ultraviolet rays. Interface between dermis and epidermis flattens, making the skin more vulnerable to shearing injuries and skin tears. Benign and malignant changes to the skin are more common in advanced age. Items found in the resident's history can give clues to the risk for skin problems. Test skin turgor by gently pinching various areas of the skin. Due to the prevalence of poor turgor related to age-related changes, it's recommended to pinch the skin over the sternum or forehead, as these areas tend to lose less turgor than other areas. For temperature, use the back of your hands. Touch the cheeks and extremities of the resident to obtain a gross assessment of skin temperature. Note inequalities between the sides. An extremity affected with a stasis ulcer may feel cool, although it can look red and inflamed. Poor circulation can cause coolness of the skin surface. If itching or bruising is present, question as to how long these symptoms have been present and the pattern. For instance, all the time, or does it worsen at night? Review the history to determine factors that could be associated with the symptoms. For instance, exposure to a pet or the use of a new soap or stress. Note abnormalities such as lesions, rashes, bruisings, discolorations, and wounds. If abnormalities are present, describe the details in your documentation. Lesions are areas of the skin that look different compared to the surrounding skin. Examples are shown here. People with the highest risk factors for skin cancer are those with a lighter skin color, blue or green eye color, blonde or red hair, family or personal history, sun exposure, history of sunburns, indoor tanning, certain types of, and large numbers of moles. These are some common types of rashes. Be aware that some rashes may have a combination of different types of lesions, like papules, pustules, vesicles, and so on. A bruise indicates bleeding from small vessels when soft tissue has been bumped or injured. Lesions from bleeding can include petechiae and purpura. Skin tears can be caused by friction, shear, or blunt trauma. They can be partial or full thickness. It helps to select the best description of the type of tissue present in any pressure ulcer bed. Epithelial tissue is the new skin growing in superficial ulcers. It can be light pink and shiny, even in persons with darkly pigmented skin. Granulation tissue is pink or red tissue with shiny, moist, granular appearance. Slough is yellow or white tissue that adheres to the ulcer bed in strings or thick clumps. Necrotic tissue, or eschar, is black, brown, or tan tissue that adheres firmly to the wound bed or ulcer edges. It may be softer or harder than the surrounding skin. The definitions for pressure ulcers were revised by the National Pressure Ulcer Advisory Panel in 2016. As you will note, they are not referred to as pressure ulcers anymore, but pressure injury. These slides will review the features of pressure injuries at various stages. Here is stage 1 and stage 2. Stage 3, stage 4, and those that are unstageable. Deep tissue injury wounds consist of intact or non-intact skin with localized area of non-blanchable deep red, maroon, or purple discoloration, or epidermal separation revealing dark wound bed or blood-filled blister. There can also be medical device-related pressure injury and mucosal membrane pressure injury. These cannot be staged. When documenting wounds, include the specific anatomical location. If there is a rash, describe the pattern or distribution of the lesions, for instance, linear or satellite. Specific measurements, and do it in millimeters or centimeters. Use a clock to reference shape and/or dimensions of the wound. Describe the wound edges and the surrounding tissue. Describe the tissue type in the wound. If mixed, use correct proportions. And the type and amount of drainage. To help determine the risk for skin problems, a scale can be used. Most facilities use the Braden scale to determine risk. It's used upon admission and generally quarterly thereafter. However, the information from the Braden scale rarely makes it to the care plan. This slide includes an abbreviated sample of the Braden scale so that it fits into the slide, but it has the major categories and point allocations. A score of 18 or below indicates risk. The lower the score, the higher the risk. The score is irrelevant to the care plan. You must address the specific risk in order to prevent skin problems from occurring. If you take time to complete the Braden scale, you must use the specific information. You don't want it to show that you've identified risk and then did nothing about it. Intervention should be matched to each one of the risks or contributing factors that you have identified. Again, if you identify a risk on the Braden scale that you don't include in the care plan and that resident develops a problem because of that risk, you could be considered to be non-compliant. Thank you for participating in this program. If you have any questions, please consult with your staff development instructor or charge nurse. Thank you.